I have no disclosures related to this talk. One of my heroes, Walter Cronkite, who said in 1993, America's healthcare system is neither healthy, caring, nor a system. And I think that because of that, we have now heard a lot from the Institute of Medicine, from CMS, from the government about the triple aim. And I am no expert in the triple aim. We're going to hear from an expert, but I'm going to talk about how ECHO fits into the picture. And this is the quadruple aim promulgated by Geisinger Health Center to improve the patient experience, improve the health of the population, lower per capita costs while improving the physician experience. Because if we make it so impossible for the physicians to practice, the patients are going to be in trouble. The Institute of Medicine reports, including to Error is Human and Preventing Medication Errors, recognize that there were a number of problems in American medicine, increasing costs consuming more of the GDP each year, and there was evidence of poor performance on quality indicators. The government thought that the solution is to reward providers for performance and align incentives. And the GAO in 2008 reported that there had been a doubling of expenditures on medical imaging between 2000 and 2005, up to $14.1 billion in 2005, and a third of that was on cardiovascular imaging, much of it on echocardiography. This is a data that shows all heart imaging increasing dramatically, while the number of Medicare enrollees did not increase as fast, making many people feel that there was too much cardiac imaging and that there was a wide disparity in how much imaging was done in each part of the country. Our own Ellen Perlman, a past president and editor-in-chief of the Journal of the American Society of Echo, published this paper in 2008, where he showed that the difference in geographic distribution and utilization of echocardiography had a lot to do with the distribution of heart failure in the relevant populations, and was not just a scattergram, but actually there was a reason for the difference in imaging. And so we come to the question of whether echocardiography can be used as a value-based cardiac care. A lot of things have to change for value-based care. Consumers have to be more actively engaged. We need to adopt safer and effective drugs and devices rapidly. Clinicians need to deliver reliable, appropriate, rapid care that's just enough care and not too much, eliminate unnecessary tests and therapies, and contain supply chain costs. ECHO has a number of advantages, and we've already done a lot of work in our field in looking at value and the things that you need to be a value-based item. We have standardization. We have participated in appropriate use criteria for many years. We have established protocols for imaging, not just the normal patient, but LVADs, heart failure, valvular disease. We just with our publication on LV and cardiac chamber quantification have standard normal values. We have quality standards, both in accreditation and certification, and there also are appropriate utilization criteria where you look at a disease such as heart failure or shortness of breath and then see what is an appropriate imaging test in the full spectrum of cardiac imaging. And you can see that echo is really appropriate in all situations where other cardiac modalities may not be. In addition, it's important to remember that there is evidence that there is underuse of echocardiography. And I'm just going to help you look at a few of these studies. This is from a Medicare database of patients who presented with their incident episode of heart failure, and 34% of patients in this Medicare database did not have an LV ejection fraction assessment within 6 months of their presentation, when obviously it is a meaningful use criteria and recommended for heart failure management. This study by Steve Farmer looked at the Cardiovascular Research Network heart failure study, so a group of patients who were enrolled in a study. In the echo subgroup, 20% of patients who presented with their incident episode of heart failure, 20% of them did not have a characterization of their ejection fraction within 180 days of their presentation. So this is underuse of echo. Here's another example. This from another Medicare database looking at 2,000 women getting trastuzumab for breast cancer. This data is a different way of looking at it. Each vertical line here is one patient. So you can see that most patients at time 0, so baseline, got a characterization of their ejection fraction by MUGA or echo, but the black dots indicate patients who never had an echocardiogram. In addition, this data is the same. Each line up is a patient and when they had their EF checked. When you're getting trastuzumab, you're supposed to be checked at baseline and every 3 months. So you can see a dark line here at 3 months, a little dark line here at 3 months, perhaps something at 6 months, and then just a scatter. This means that the majority of patients did not have appropriate screening by echo during chemotherapy, and in fact, only 36% of patients in this study had appropriate screening. We have participated for years in appropriate use criteria in an effort to decrease overuse of echo. And you will know that most echoes are not ordered by echocardiographers. Here's a patient, and the doctor says, looks like a paper cut, let's get an echo to be sure. I'll tell you a story about the hospital of the University of Pennsylvania, where between 1995 and 2008, when I was the Echo Lab director, our volume tripled. And in 2008, half of these patients were inpatients. We noticed that approximately 15% of hospital inpatient studies were ordered for Kawasaki's disease. The peak age of Kawasaki's disease is 1 to 2 years of age, and HUP does not admit children. And so if you look at how many cases of Kawasaki's disease in the country, there were 5,000 cases in 2006. So this doesn't make sense. And we have the electronic medical record to thank for this trend, because Kawasaki's disease is also known as acute mucocutaneous lymph node syndrome. Now at Temple University Hospital, we are seeing a rash of patient studies ordered for abnormal ECG. And those of you who know the ways of house officers will realize that alphabetically, these are the first drop-downs in the drop-downs for why an echo is being ordered. And as so many house officers say to me when I call to cancel the echo, but Dr. Wiegers, what is the harm in doing another transthoracic echo? And so I just want to talk about the harm that we can do by doing too many echoes. Here's a 45-year-old patient. We were called to the ER. The ECG was said to be non-qualifying, but he looked like he was having an MI. We did the echo and said, yeah, he's having an LAD infarct. And I said, let me see the EKG. Couldn't find it. They did one, and here it is. That echo hurt that patient because it increased their door-to-balloon time by 20 minutes. Echoes, unindicated echoes withhold resources from appropriate or indicated studies. We have misinterpretation of images, misinterpretation of the report. When we think we are being perfectly clear when we say RV volume and pressure overload, but it doesn't necessarily mean that you treat an RV infarction with diuresis because of volume overload. Incidental findings increase downstream testing, and it can increase length of stay while you're waiting for that pre-discharge echo. Henri Bergson often said, repetition is a form of humor, but CMS doesn't think this is funny. We try to tell the SICU, we're not going to be able to see anything. But echo in the value proposition, it's reproducible, it's portable, it's scalable, and it is the safest imaging test. CT combined imaging has reduced the radiation significantly. This is recent data from Core 320 study, but echo radiation dose is still 0. Dr. Porter, a proponent of value-based care, notes that outcomes are inherently multidimensional and include the degree of health or recovery achieved, the time needed for recovery, and care of the discomfort of the care and the sustainability of recovery. I show you this to remind you that the cheapest test is not necessarily the most valuable test. So on the left, we have an echocardiogram in a hypotensive patient. And here on the right, we have the added cost of a commercial agent used to show that the LV is in fact hyperdynamic and the RV is akinetic in this patient who's hypotensive because of a pulmonary embolism. So contrast is a very important part of our armamentarium in providing value-based care. And in fact, lots of data, this from 2000, shows that fundamental imaging, harmonics, but contrast allows ejection fraction wall motion analysis in almost 100% of patients. So the ASC stands for Quality in Cardiovascular Ultrasound, the right test in the right patient at the right time. And I want to remind you that one of our strategic plans is reaching out to point of care users. And there's a reason, not just because it's going to happen with or without us, but because it's the right thing for patients. Here are a couple of studies. This is from Europe. Patients who were scanned with a handheld and with the high-end device, their ejection fractions did not differ. A study by Kirk Spencer in Chicago showed training house officers to use point of care allowed the ejection fraction to be characterized 22 hours earlier than the standard of care ordering a full echo from the echo lab. A study from London estimated that 30% of standard echoes at a savings cost of a great deal of money could be obtained by doing handheld echoes and eliminating studies on normal patients. And Dr. Call has also shown the same thing. Here's a study from Poland where the internist learned handheld echo over the course of a month and then did studies on patients and just characterized them as normal EF, LVH, and big LA, or any valve pathology. And this physician was able to show in a group of 200 patients that an abnormal echo predicted events where a normal echo predicted event-free survival. So echo is the right tool, and the ASC continues to get out the message. For clinical care, we need to work to standardize indications to avoid underuse and overuse. We need to apply the appropriate use criteria and figure out a way to help our colleagues who are ordering the studies to tell us the real indication and apply appropriate use. We need to think about scaling imaging. We don't, when we're checking to see if the pericardial effusion has reaccumulated, we don't need to do the full 80-clip study. And we need to coordinate with the patient at the center of care, which will make all of these changes much clearer what's driving it. Similarly, echo has real value in research and in innovation, and will continue to be the main imaging cardiac technique in the future. Thank you for your attention.